What the study says.
Welcome back to the deep dive. Today we're cracking open a pretty substantial stack of sources, articles, research papers, clinical guidelines, you name it.
All focused on bipolar disorder.
Exactly. And it's a condition that, well, it affects a lot of people, but it often seems to get oversimplified or sometimes missed entirely during diagnosis.
That's right. It can be really complex.
So our mission here in this deep dive is to pull out the key insights from all this material. We want to give you a clear, really grounded understanding of what bipolar disorder actually is, how clinicians go about diagnosing it, and what the management looks like. Always keeping that real-world impact front and center.
Yeah, moving beyond just the headlines and getting into what the research actually tells us.
Okay, so let's start unpacking this. When people hear bipolar, I think the first thing that comes to mind is often just mood swings, maybe, really high highs and low lows.
Right, but the sources really emphasize it's more structured than that. It's defined by specific, distinct episodes.
Episodes, okay.
Yeah, that's the crucial starting point. It's not just random shifts. It's characterized by these clear episodic periods. You have elevated or irritable mood states, what we call mania or hypomania, and then also periods of major depression.
And these aren't just vague feelings, are they? The sources, they lay out pretty specific criteria, often based on the DSM-5-TR. What do they say about, say, a manic episode?
A manic episode, yeah, the sources describe it as quite severe. It has to last at least one solid week continuously.
A full week.
Or it could be any duration if the person actually needs to be hospitalized because of it. And it involves this persistently elevated, expansive, or sometimes irritable mood, plus a really noticeable increase in activity or energy.
So is that combination mood and energy or activity?
Exactly. And alongside that, you need to see at least 3 specific symptoms, or 4 if the mood is only irritable, reaching a significant intensity. The sources list things like inflated self-esteem or grandiosity.
Like kind of on top of the world, maybe?
Or feeling they have special powers sometimes. Also, a dramatically decreased need for sleep. Someone might feel totally rested on just, say, 3 hours.
Wow.
Being much more talkative than usual, or feeling this pressure to keep talking. Racing thoughts, like their mind is just speeding, hard to follow.
Yeah.
Being easily distracted.
Racing thoughts and distraction. I mean, that sounds like it would make just everyday life incredibly difficult.
It absolutely can. Other symptoms include a big increase in goal-directed activity, could be work, social, sexual, whatever, or sometimes just pointless physical agitation like pacing.
Okay.
And a really key marker, the sources point out, is getting excessively involved in activities that have a high potential for painful consequences. Think, spending sprees, reckless driving, risky sexual encounters, foolish business investment.
Right, that high-risk behavior driven by that state. Okay, so that's mania. What about hypomania? How's that different?
So hypomania shares a lot of the same symptoms. The elevated or irritable mood, the increased energy, those associated symptoms we just listed. But the sources define it as less severe and shorter.
Less severe, shorter duration.
Yeah, it needs to last at least 4 consecutive days. And crucially, the sources highlight that a hypomanic episode, by definition, does not cause that marked impairment in social or occupational functioning that you see in mania.
Okay, so life doesn't completely go off the rails.
Right, and it doesn't require hospitalization. Another key difference. Psychotic features like delusions or hallucinations are absent in hypomania. If psychosis shows up during an elevated mood state, it's automatically considered mania.
Got it. So hypomania is like a less intense version, doesn't totally disrupt life, no psychosis.
Yeah.
And then, of course, there's the other side of the depression.
Exactly. And the major depressive episodes in bipolar disorder, they're described pretty much just like major depressive disorder or unipolar depression.
Classic picture.
Yeah, a period of at least 2 weeks with either a depressed mood or significant loss of interest or pleasure in, pretty much everything.
Okay.
Plus at least 4 other specific symptoms. The sources mention things like big changes in weight or appetite, sleep problems, either insomnia or hypersomnia, sleeping too much fatigue, feeling worthless or excessively guilty, trouble concentrating or making decisions, and importantly, thoughts of death or suicide.
And again, these have to cause real distress or impairment.
Absolutely. Clinically significant distress or impairment in functioning.
So it's really the swing between these defined specific episodes, mania or hypomania, and depression that creates the core pattern of the illness.
Precisely. And the specific pattern of those episodes determines the main subtypes the sources talk about. First, there's bipolar I. That's defined by having at least one manic episode. Just one is enough.
One manic episode, you're in the bipolar I category.
Correct. The sources add that most people with bipolar I also have major depressive episodes, and often hypomanic ones too, but the mania is the key requirement.
Okay, and bipolar 2?
Bipolar 2 is diagnosed when someone has had at least one hypomanic episode and at least one major depressive episode. But, and this is crucial, they have never had a full manic episode.
Hypomania plus depression, no mania. Got it.
Yeah. And an interesting side note from the sources is the suggestion that bipolar 2 might be diagnosed a bit more often in females, and perhaps seasonal patterns episodes linked to seasons might be more common than in bipolar 1, but those are just associations mentioned.
Interesting nuance. What about cyclothymic disorder? That sounds a bit different.
It is. Cyclothymic disorder, according to the sources, involves numerous periods with hypomanic symptoms and periods with depressive symptoms. But crucially, these symptoms don't meet the full criteria for an actual hypomanic or major depressive episode.
So kind of sub-threshold symptoms.
Exactly. And this pattern has to persist for at least 2 years, 1 year in kids and adolescents, with the symptoms being present for at least half the time, and no more than 2 months straight without any symptoms. It's seen as a more chronic, kind of lower grade fluctuation compared to the really distinct episodes of bipolar 1 and 2.
It really sounds like these definitions are all about pinning down specific clusters of symptoms, their intensity, and how long they last. Not just, having good days and bad days.
That's absolutely right. Precision is key. Right. And the sources make it clear this isn't some rare condition. They mention prevalence rates around 2% of U.S. adults, with similar global estimates.
2%. That's millions of people.
It is. And what really jumped out at me from the sources was how often it seems to be underrecognized or misdiagnosed, especially in primary care settings.
Oh, really?
Yeah, one source mentioned a positive screening rate in primary care that could be as high as like 9.8%. And another estimated that maybe up to 17%. 17% of patients being treated for major depression in primary care might actually have unrecognized bipolar disorder.
Wow, 17%. That's huge. That points to a massive diagnostic challenge right there.
It really does. And it underscores the burden of the illness, too. The sources mention it ranks as the 17th leading cause of disability worldwide and carries a significant economic cost.
Which leads us perfectly into the next big thing the sources cover, this whole diagnostic maze. Why is it so tricky to get this diagnosis right, both for patients and for clinicians?
Yeah, this is where it gets really complex, and the sources point to several key reasons. A big one is just symptom overlap.
Right, we touched on that.
Yeah, like irritability, increased activity, distractibility. Those aren't exclusive to bipolar disorder. They can easily look like symptoms of ADHD or conduct disorder or ODD, especially in younger people. And of course, the depressive symptoms themselves look exactly like unipolar depression. So the building blocks can seem similar across different conditions.
The raw ingredients can show up in different recipes, so to speak.
That's a good way to put it. Another really significant factor is how the illness often starts. The sources consistently note that the first episode for many people is a depressive one.
God.
So someone might have several episodes of severe depression, get diagnosed with major depressive disorder, maybe treated for years, before they ever have a clear manic or hypomanic episode that gets recognized.
So if the elevated mood pole hasn't even appeared yet, the bipolar nature is basically invisible at first?
Exactly. It's hidden. And then patients themselves sometimes contribute to the difficulty, often unintentionally. They might simply forget past episodes, especially if they happened years ago.
Right.
Or they might not have recognized them as part of an illness at the time. This seems especially true if the episode involved more irritability or agitation rather than, classic euphoria. They might just remember being really stressed or angry, not manic or hypomanic.
I can definitely see how getting a complete, accurate history could be really tough in those situations. Requires a lot of careful questioning.
It really does. Thorough detective work, almost. And then you layer on comorbidity. The sources hammer this point home. Co-occurring conditions are incredibly common. Anxiety disorders, substance use disorders, personality disorders.
All happening at the same time.
Yes, and they can seriously muddy the waters. They can mask the bipolar symptoms or complicate the presentation, making it much harder to clearly identify those distinct mood episodes.
It really sounds like a perfect storm of factors that can lead to significant diagnostic delays for people. So given all that, how do the sources say clinicians should try to navigate this complexity to actually get it right?
Well, the sources really stress the need for a thorough, comprehensive evaluation, No shortcuts. This means getting a detailed psychiatric history, of course, but also a general medical history, doing a mental status exam, a physical exam.
The basics, but essential.
Absolutely. And they also recommend a basic set of lab tests, things like checking thyroid function, maybe a complete blood count, basic chemistries, and often a urine toxicology screen to rule out substance effects.
Standard practice to rule out other medical causes.
Crucial here. But the absolute key, according to the sources, is meticulously assessing the pattern of past mood episodes. You need to know the number, the frequency, the intensity, the duration of any potential past episodes. That historical pattern is what really distinguishes bipolar disorder.
So history is everything.
It's paramount. And interviewing family members or close friends with the patient's permission, of course, can be incredibly valuable. They might remember episodes or details the patient has forgotten or didn't recognize at the time.
Right, they can help fill in those gaps. Now, the sources also mention screening tools, don't they? Things like the MDQ.
They do, yeah. Tools like the Mood Disorder Questionnaire, or MDQ, and the Rapid Mood Screener are mentioned. They're designed as quick screens for potential mania or hypomania.
Okay, so are they helpful?
Well, here's a really important caveat from the sources. While these tools exist and are sometimes recommended for screening, it's actually not definitively known if using them routinely improves patient outcomes.
Oh, that's interesting. So they might flag potential cases, but don't necessarily translate to people getting better.
The evidence isn't clear on that outcome link. The sources are quite cautious, stating it's not clear that these instruments perform well enough for routine use, especially in general outpatient psychiatric clinics. They tend to have a higher rate of false positives compared to a detailed clinical interview.
So more likely to flag someone who doesn't have it than miss someone who does.
Potentially, yes. Or at least they generate positives that don't hold up on full evaluation. So the takeaway is, a positive screen is just a signal. It means you need to do that thorough clinical interview we talked about. It's definitely not a diagnosis in itself.
Okay, so they're a potential flag, not the finish line. What about tools for tracking things over time? Once someone maybe has a diagnosis or it's suspected.
Ah, yes, mood charting. The sources really highlight the value of this, particularly for long-term management. They discuss tools like the NIMH Life Chart method, which is quite detailed, or even simpler daily mood charts.
What do those involve?
Basically, the patient tracks key things daily. Their mood level, maybe on a scale, hours slept, anxiety levels, irritability, any medications taken, substance use, sometimes even weight.
And how does that kind of consistent tracking help?
Well, the sources say it's really valuable for long-term monitoring. It helps both the patient and the clinician see patterns emerge, identify potential triggers for episodes, recognize symptom-free intervals, track how well medications are working, and monitor adherence. It creates a visual history that can be super informative over time.
Yeah, I can see that. It gives you something concrete to look back on and understand the illness trajectory better. Switching back to the diagnostic process itself, the sources talk a lot about the differential diagnosis, right? Separating bipolar disorder from other things that might look similar.
Absolutely crucial, given all that symptom overlap we discussed. You have to systematically rule out or identify other possibilities.
Okay, let's break down a few key ones the sources mention. How do they differentiate it from, say, unipolar major depression? That seems like the most common confusion point.
It is. And the absolute definitive distinction, according to all the sources, is the lifetime history. Unipolar depression is defined by the absence of any history of manic or hypomanic episodes. Full stop.
Simple as that. In theory.
In theory. But because bipolar disorder so often presents first with depression, the sources do detail some features that might be more common in bipolar depression versus unipolar depression. Things like sleeping way too much hypersomnia, significant psychomotor slowing, like feeling physically slowed down, marked weight gain or increased appetite, feeling excessive or inappropriate guilt, and sometimes having psychotic features during the depressive episode.
Interesting clues.
Clues, exactly. But none are diagnostic on their own. They also mention that sometimes a poor response to standard antidepressants might raise suspicion that it could actually be underlying bipolar depression. But again, at the end of the day, it comes back to that history. Has there ever been a manic or hypomanic episode? That's the decider.
So history of the up pole is the key. What about schizoaffective disorder? That one also involves both mood episodes and psychosis.
Right. Tricky overlap there, too. But the sources draw a clear line based on the timing of the psychosis relative to the mood episodes.
Okay, how so?
In bipolar disorder, if psychosis occurs, it happens only during a manic episode or a major depressive episode. In schizoaffective disorder, the diagnostic requirement is that the person must experience psychotic symptoms like delusions or hallucinations for at least 2 weeks in the absence of a major mood episode.
Ah, so psychosis happening outside of the mood swings points towards schizoaffective. That's a clear distinction.
It is. Then there's borderline personality disorder, or BPD, known for mood instability, impulsivity.
Yeah, lots of overlap in symptoms there, it seems.
Definitely. And high rates of comorbidity, too, meaning someone can have both. BPD shares features like intense mood shifts, irritability, impulsivity, suicidal behavior. However, the sources typically point out that the affective instability in BPD is often described as much more rapid and transient, shifting over minutes to hours, often triggered by interpersonal events.
Compared to bipolar episodes lasting days or weeks.
Exactly. Bipolar mood episodes have a more sustained quality, allowing days, weeks, or even months. The sources also suggest that trying to diagnose a personality disorder like BPD is often best done when the person's mood is relatively stable, as an acute manic or depressive episode can sometimes mimic or exaggerate personality traits.
Makes sense. Stabilize the mood first, then assess the underlying personality patterns. What about substance use disorders? You mentioned they're highly comorbid.
Extremely common. Sources cite figures like around 50% lifetime prevalence of a comorbid substance use disorder in people with bipolar disorder.
Wow.
And substances can absolutely mimic mood symptoms, both highs and lows. The diagnostic principle here, according to the sources, is that a bipolar diagnosis requires that the full criteria for mood episodes are met during periods when the person is not acutely intoxicated or withdrawing from substances.
So the episodes have to occur independently of substance use.
Right. Though realistically untangling that can be very difficult in practice. And crucially, comorbid substance use makes everything worse. It worsens the course of the bipolar illness, complicates treatment, increases risks.
A major complicating factor. What about conditions often diagnosed earlier in life, like ADHD, conduct disorder, ODD? They share things like hyperactivity, impulsivity, irritability.
Yeah, particularly relevant for diagnosing in adolescents or young adults. The key distinction the sources emphasize again is the episodic nature of manic or hypomanic symptoms.
Episodic versus chronic.
Exactly. In mania or hypomania, symptoms like hyperactivity, impulsivity, distractibility, and irritability occur together in a distinct cluster, clearly representing a change from the person's usual baseline and intensifying alongside that abnormal mood state, elevated or irritable. If those traits are more chronic, persistent, and don't fluctuate dramatically with distinct mood shifts, it's less likely to be bipolar mania. But again, comorbidity is high. Someone can have both ADHD and bipolar disorder.
The episodic pattern seems to be the critical differentiator across the board. And finally, ruling out medical causes.
Absolutely fundamental. The sources list numerous general medical or neurological conditions that can present with mood symptoms mimicking bipolar disorder. Things like thyroid disease, stroke, brain tumors, traumatic brain injury, infections like HIV or syphilis, certain autoimmune diseases, neurodegenerative disorders like Huntington's.
Well, long list.
It is. So a medical workup guided by the patient's history and physical exam is essential. And they also stress checking the person's medication list very carefully. Some prescribe drugs, corticosteroids are a classic example, but also some Parkinson's meds. Stimulants can induce manic or depressive symptoms.
So before landing on a bipolar diagnosis, it's this really thorough process. Confirm the specific episodic pattern, get the longitudinal history, and carefully rule out substances, medical conditions, and other psychiatric disorders. It sounds like it can be a really complex and often lengthy diagnostic journey for many people.
It really can be. And the sources certainly don't minimize the challenges of living with the condition once it is diagnosed. They talk quite a bit about the typical course and potential complications.
What do they say about the course? Is it something people grow out of?
Unfortunately, no. The sources describe it as typically recurrent and often lifelong. It's not usually a one-time event.
So episodes tend to come back.
Yes, most individuals will experience recurrences throughout their lives. An interesting point from the sources, especially regarding youth, is that after the first episode, something like over 70% of the subsequent recurrences tend to be depressive episodes.
Oh, wow. So even if mania or hypomania was the initial trigger for diagnosis, depression might actually be the more frequent struggle long-term for many younger people.
That's what some data suggests, yeah. The typical age of onset is often around age 20, give or take. And the sources note that an earlier age of onset is generally linked with a poorer prognosis.
Poorer how?
Things like longer delays in getting the right diagnosis and treatment, experiencing more severe or chronic depression, and having higher rates of those comorbid conditions we keep mentioning: anxiety, substance use, ADHD.
Comorbidity really seems to be a shadow hanging over everything, impacting the course significantly.
It absolutely is. The sources consistently link co-occurring psychiatric disorders. Anxiety disorders are incredibly common, like panic disorder, GAD, social anxiety plus substance use, ADHD, personality disorders, PTSD, OCD, and also general medical illnesses like cardiovascular disease, diabetes. All of these are associated with worse outcomes,
Meaning what, specifically?
meaning things like an earlier onset of the bipolar disorder itself, more frequent mood episodes, poor overall functioning between episodes, a higher likelihood of suicide attempts, and less chance of achieving full recovery or remission from episodes.
So managing those co-occurring conditions effectively is just as critical as managing the bipolar disorder itself.
It has to be part of the overall treatment plan, definitely. The sources also bring up cognitive impact. Many patients, even when they're euthymic meaning stable, not in an acute episode, experience cognitive deficits.
Like memory problems.
Yeah, issues with attention, memory, executive function planning, problem solving. Also social cognition, like understanding social cues. These can stem from the illness itself, potentially medication side effects or those comorbidities. It's another layer of challenge that can impact daily life and work, even during periods of stability.
That's tough. What are the most serious risks the sources emphasize when talking about living with bipolar disorder?
Well, increased mortality from all causes is noted, but the most stark risk discussed is suicide.
Yeah, you mentioned that earlier.
The figures are alarming. The sources consistently state that suicide attempts are common, with estimates around 20%, 1 in 5 people with bipolar disorder attempting suicide at some point in their lifetime.
1 in 5, that's incredibly high.
It really underscores the lethality potential. The sources list risk factors for attempts. A history of past attempts is the strongest predictor. Feelings of hopelessness, being in a depressive episode, or experiencing mixed features, that's having symptoms of both depression and mania hypomania simultaneously.
Mixed features sound particularly dangerous.
They're considered high risk. For death by suicide specifically, male, gender, and that history of prior attempts are highlighted risks. Bipolar disorder consistently ranks as having one of the highest suicide rates among all psychiatric conditions.
It just highlights the absolute critical need for effective, ongoing treatment and support.
Yeah.
Did the sources mention other risks, like interactions with the legal system?
Yes, they did touch on that. One study mentioned found a lifetime prevalence of incarceration around 31% in their sample and calculated about a 1.5 times higher risk compared to the general population, even after adjusting for other factors. They also mentioned links to violent criminal behavior, but the sources add a nuance there. Studies comparing this risk specifically to other severe psychiatric disorders have produced mixed or inconclusive results. So, while there's an association, how it stacks up against other conditions isn't definitively settled.
Got it. So a complex picture there, too. Okay, so we've talked about the definitions, the diagnostic challenges, the often difficult course, and serious risks. How do the sources talk about managing this journey? Is there hope?
Absolutely. That's a really important message from the sources. While it's clearly a chronic, serious condition, the emphasis is very much on it being manageable. They stress it's a treatable condition. One source even used the metaphor of epilepsy, another chronic brain illness, that while requiring ongoing care, most people can learn to manage effectively and live full lives.
I like that framing. It acknowledges the seriousness, but emphasizes agency and effective treatment. What's considered the cornerstone of management, according to the sources?
Pharmacotherapy medication is consistently described as the cornerstone, especially for maintenance therapy, meaning long-term prevention of episodes.
So medication isn't just for acute episodes?
No, the sources strongly suggest considering maintenance medication for pretty much every patient once they achieve stability after an episode. There's observational data mentioned suggesting that starting preventative treatment early, for example, starting lithium after a first manic episode, might be linked to better long-term outcomes, like fewer hospitalizations down the road.
So medication is really key for preventing those future episodes and maintaining stability. What kinds of medications are we talking about?
Well, for treating an acute manic episode, the sources often suggest that starting with combination therapy is frequently more effective than using just one drug alone, especially if the mania is severe.
Combination like what?
Typically a mood stabilizer like lithium or valproate depakote, combined with an antipsychotic medication. There are many medications listed as effective options in the sources: lithium, valproate, quetiapine, Seroquel, olanzapine, Zyprexa, risperidone, Risperdal, aripiprazole, Abilify, ziprasidone, Geodan, acetylpine saphras, carbamazepine, Tegretol, cariprazine, Vraylar, even haloperidol, Halbal, for acute situations.
Lots of options there.
Yes, a range. They even mentioned a couple of less standard options for really tough cases like tamoxifen or even blue-blocking glasses based on small studies, but those aren't frontline treatments.
Okay. And then for staying well long-term, for maintenance.
Often, the medication that worked to get the person out of the acute episode is the one that's continued for maintenance. Lithium, valproate, and quetiapine, either used alone or sometimes in combination, like lithium plus valproate, are frequently highlighted in the sources as having good evidence for preventing both manic and depressive relapses.
And you mentioned lithium might have another benefit.
Yes. The sources specifically note that long-term lithium treatment appears to have a unique potential benefit of reducing the risk of suicide in people with bipolar disorder. That's a very significant point.
Definitely. What about monitoring? These sound like powerful medications.
Monitoring is absolutely essential, and it varies depending on the drug. The sources stress this. For example, with many antipsychotics, you need to monitor weight, blood glucose, and lipids because of metabolic risks. With lithium, regular checks of kidney and thyroid function are crucial. With drugs like clozapine or carbamazepine, blood counts need monitoring. Lamotrigine requires watching for rash as part of safe prescribing.
And are there special considerations for certain groups, like women who might become pregnant or older adults?
Yes, very important points. The sources explicitly state that certain mood stabilizers, particularly valproate and carbamazepine, carry significant risks of birth defects if taken during pregnancy, so they are often avoided or used with extreme caution in women of childbearing potential. For older adults, clinicians need to be extra careful about potential drug interactions with other medications they might be taking for medical conditions, and doses often need to be adjusted.
So it's clearly not a one-size-fits-all approach. Treatment has to be very individualized.
Absolutely.
What about antidepressants? We talked earlier about how bipolar disorder often gets misdiagnosed as depression initially. How do antidepressants fit into bipolar treatment?
This is a critical point of caution raised in the sources. Standard antidepressants like SSRIs should generally be used very carefully, if at all, in bipolar disorder. The recommendation is usually to consider them only as a potential option for treating bipolar depression if other treatments haven't worked, and only if the patient is already taking an effective antimanic medication, a mood stabilizer or antipsychotic.
Why only with an antimanic?
Because the major concern, as you might guess, is that using an antidepressant alone in someone with bipolar disorder can potentially trigger a switch into mania or hypomania, or even induce rapid cycling between episodes.
So it could actually make things worse if used incorrectly. Makes sense. So medication is foundational. What else is important for effective management?
Adjunctive psychotherapy. Therapy used alongside medication. The sources really emphasize its importance.
Why is therapy so important if medication is the cornerstone?
Well, therapy plays crucial roles in preventing relapse, helping patients better understand and cope with the illness, improving medication adherence, which can be a challenge managing stress, and improving overall functioning and quality of life. It's typically started or most effective once the patient is relatively stable or euthymic so they can fully engage.
What kinds of therapy do the sources find most helpful?
They actually suggest adjunctive group psychoeducation as a first-line psychotherapy approach.
Psychoeducation. So learning about the illness.
Exactly. It's structured education for patients, and often their families, about bipolar disorder itself, what it is, its typical course, the role of medications, how to identify early warning signs, prodromes of an impending episode, and strategies for staying well, empowering people with knowledge.
That seems incredibly valuable, learning to manage the condition proactively.
Absolutely. Other types of therapy with good evidence mentioned include cognitive behavioral therapy, CBT, often adapted for bipolar disorder, family-focused therapy, FFT, and interpersonal and social rhythm therapy, IPSRT, which focuses on stabilizing daily routines. The sources also suggest that sticking with the same type of therapy from the acute treatment phase into the maintenance phase might lead to better outcomes.
Continuity seems important there too. Are there other management strategies the sources touch on?
Yes. Ongoing symptom monitoring and tracking, using those mood charts we talked about, is highlighted again as a valuable self-management tool. They also discuss managing acute agitation if it arises. The first step is always to rule out underlying causes like substance use or a medical issue. If needed, short-term use of benzodiazepines or antipsychotics might be considered. There's also mention of a newer sublingual film, dexmedetomidine, for mild to moderate agitation.
Okay, so there are tools for managing acute symptoms as well. What about for really severe treatment-resistant episodes?
For severe mania or depression that hasn't responded to medications, electroconvulsive therapy, or ECT, is noted in the sources as a highly effective treatment option.
Good to know there are options for even the most difficult situations. How can the broader healthcare system support better management, especially since many people first show up in primary care?
The sources point to the potential benefits of implementing the chronic care model, particularly in primary care settings. This model emphasizes things like integrated care between mental health and primary care, patient self-management support, decision support for clinicians, and using clinical information systems to track patients. Studies suggest it can lead to better outcomes for chronic conditions like bipolar disorder compared to usual care.
A more systematic, supportive approach seems key. And finally, did the sources mention resources for patients and families who want to learn more?
Yes, they did. They specifically noted patient education materials like the Up-to-Date Basics and Beyond the Basics articles, which are often available online, and also mentioned a booklet on bipolar disorder published by the National Institute of Mental Health, NIMH, as being valuable resources for reliable information.
Great. So wrapping up this deep dive, it's clear that bipolar disorder is, well, it's a complex illness, no doubt about it. But the overwhelming message from the sources is that it is treatable and manageable.
Absolutely. Getting that accurate diagnosis, which we've seen can be a real challenge due to symptom overlap and how it often first presents as depression, is such a critical first step.
And then consistent, comprehensive management is key. Anchored by appropriate medication often needed long-term for maintenance to prevent relapses and significantly supported by adjunctive psychotherapies like psychoeducation, CBT, or family therapy. That combination seems vital for achieving stability, reducing those recurrences, and really improving quality of life.
It really is a journey of ongoing care and partnership. It's not just about treating acute episodes reactively. It's about proactive long-term management. It requires that collaboration between the patient, their support network, family, friends, and their clinical team.